we're presenting on our Sleep for Health in Hospital and at Home projects. I'm Dr. Megan Thomas. I'm a developmental paediatrician and associate professor in the Department of Paediatrics at Dalhousie University. Also presenting with me today is Victoria Foxall, who did her undergraduate thesis with me on one of these projects, and then rather fabulously has been working as the research coordinator. And I was meant to correct that slide, sorry folks, deliberate mistake, on the Shhh project, and Momina Roger, who is a clinical psychology doctoral student who I co-supervise with Isabel Smith. And in one of those lovely circles of life moments, so Victoria, who's done her undergrad at Dal, is going to the University of Toronto in the fall to start her clinical psychology doctoral studies. And Momina did her undergraduate at the University of Toronto and is now with us here at Dal. Yeah, is it changing? No, that would just be too easy. Why are you not changing? Anyone give me a clue why it won't change?
I don't know. I mean, usually if you can upload. Oh, there you go. Working now. Good.
Just a huge time lag. Okay. I wanted to acknowledge that we are located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. We also acknowledge the histories, contribution and legacies of the African Nova Scotian people and communities who have been here for over 400 years. We don't think we have any conflicts of interest to declare, and we do have a number of funding sources over our different projects, and we think we've captured them all here. So the objectives of our session today are to describe our work on supporting healthy sleep in hospital and at home, encourage people to consider sleep as a patient-reported outcome measure in the research they're doing, and we're really keen to collaborate with other people. So again, this was a way of perhaps getting us a little bit known in the research community to see if we can either support your project with regard to sleep or you can support our projects. Overview of the presentation. So why sleep? Why in hospital? Why in hospital and at home? A little bit about our guiding principles and frameworks, how we're now translating this knowledge into care, how we've responded to different priorities that have been highlighted, and what's next. So we're a small group. I did say that we might make up most of the group, and I think we do. So people feel free to just call out or put into the chat, have you heard about our sleep projects before?
No, to be honest, I haven't.
Yeah, I haven't.
Okay, so it's great we're here telling you about them. Thank you. So I'm just going to kind of talk you through a little bit of a timeline of the evolution of our projects. So we started with the Sleep for Health in Hospital Halifax. So we've had this shh go through, and as you will see, I do have a penchant for acronyms. So we started with that with a little bit of funding through the Paediatric Endowment Fund in March 2021. And we gathered a whole range of different data sources, so sound and light measures, time use diaries, which for those of you who aren't familiar with this type of research, that's where you're looking at how someone is, their activities throughout a 24-hour period, but also location, social contact, and we can capture mood in those as well. Sleep diaries, the parents completed on behalf of themselves and their children. We did a staff survey and we did some parent interviews. And when we were looking at all that information and collating it and coming to our conclusions, we felt we really wanted to change to Sleep for Health in Hospital and at Home, because it was very apparent that how you sleep before you are admitted to hospital affects how you sleep in hospital, and what happens in hospital affects how you sleep when you go home again. We then put in a trick application for our Shhh project. And while we were doing that, we had a parent partner involved in supporting our application, and who is a integrated member of the research team. And from his experiences, from what we heard in the original project, and also checking in the literature, we really felt that an identified priority was children with neurodevelopmental disabilities, that we needed to especially consider what additional did we need to do to support their sleep. So then we started with the Sleep for Health in Hospital and at Home 2 project in July 2023. It's a 2-year project. And so far we've undertaken focus groups with parents and caregivers, and focus groups with healthcare professionals to really co-design what an intervention plan could be to support sleep in hospital. And while we were doing that, an identified priority was supporting healthcare provider change. So that was another priority there. And then we have brought all that together to come up with Imagine Sleeping, which we will talk about in a bit more detail later. And we're just moving into evaluation and refinement and doing healthcare provider interviews and surveys and parent and carer surveys to find out how these changes are working and to further refine them with the aim of finishing the project in July. So we talked about why sleep. Well, if we look at health, the World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so when we think about healthy sleep, we're not just talking about the absence of a sleep disorder, we're talking about an important entity in itself. And it's quite hard to define healthy sleep. But a definition that I like is sleep health is a multidimensional pattern of sleep wakefulness adapted to individual, social, and environmental demands that promotes physical and mental well-being. And good sleep health is characterized by subjective satisfaction, appropriate timing, adequate duration, high efficiency, and sustained alertness during waking hours. Why is sleep important? I'll just give you just a quick reminder that healthy sleep is important for optimal daytime functioning. We need it for memory consolidation, psychological well-being. It supports healthy child development and growth. It influences our perception and resilience with regards to pain. It's important for the secretion and suppression of hormones. And crucially, when we're thinking about sleep in hospital, it facilitates healing after illness. We also need to remember that we spend approximately 1/3 of our lives asleep or trying to sleep, and in childhood that's more like half our lives. So it's really important that we don't disregard what's happening for such a large proportion of our lives. So again, a little question for you. Do you currently include any aspect of sleep in your research?
I don't actually.
Okay, hopefully you may think differently by the end.
Yeah.
Okay. So why is sleep disrupted in hospital? So from the work that we did, and then also looking at the literature and other people's work, we know that noise has a really major impact. And this is noise from multiple sources. So it might be noise from equipment in the child's room. It might be noise from healthcare providers at the nursing station. It might be noise from other patients. It might be noise from visitors. It might be noise from overhead speaker announcements. We know that lights are really important, and what certainly I was expecting to see was that light at night was a disruptor. But much to my surprise, we found that actually there was insufficient light during the day. People were in a kind of a murky semi-darkness all day long, a bit darker at night, and then being interrupted by light when people were doing checks. And as light is the biggest driver of our circadian rhythm, it's really important that we have this bright light during the day. And then clearly you're in hospital because you need care and observations, and those happen overnight as well. And things like room temperature and the comfort of your beds and things like that are important. And then moving on to the individual factors, also pain and illness factors, whether you are a very young child or a teenager, whether you're anxious and distressed, your disrupted sleep routine, and the effect of medications. Why is sleep disrupted at home? Well, actually, sleep problems are very common in childhood, and more than 30% of children and youth will have difficulties with their sleep. And when we look at children and youth with neurodevelopmental conditions, that rises to more than 80%. And while the commonest condition is behavioral insomnia, we know that there is also some significant sleep disorders which occur with some frequency within childhood. So obstructive sleep apnea around 4% of children, and there is actually an increased incidence in smaller children with their small airways. But interesting, it's also an increased incidence in ADHD, perhaps a third of individuals with that diagnosis. Restless leg disorder, estimates around about 1.92% of the child and youth population, but perhaps up to 44% in ADHD, and it's often undiagnosed and unrecognized. And obviously, sleep is disrupted by illness and changes in routines. And that's my part, and I'm going to hand over now to Victoria.
Okay, thank you, Megan. So now moving on to talk more about our research projects more specifically, and beginning with our guiding principles and frameworks. So the Shhh projects are guided by the Appreciative Inquiry Framework, and this framework emphasizes the strengths, successes, and potential within an organization. So the problems aren't ignored, but it's really about inquiry into what's already working well and suggestions for positive change. So the framework is characterized by 5 stages: define, discover, dream, design, and destiny. So the first stage involves defining the research question and the purpose of the project. The discover stage focuses on the best of what is. So for our projects, that looks like discovering the current areas of good practice and identifying how to further generalize and implement them. Dream is about what might be. So for us, that looks like dreaming about other possibilities and desired changes for promoting healthy sleep in hospital and at home. Design is about what will be. So we are designing intervention strategies that also include tailored information resources that respect families from different cultural, socioeconomic, health, and family structure backgrounds. And then finally, we have destiny, which is all about sustaining those developments. And so we are collaboratively implementing and sustaining our intervention plan that we're putting in place. And then as well, all of our projects are built on the experiences, wants, and needs that families have shared with us. And we are continuously gathering input from families through many different means in both formal and informal ways. And then we take that information and we use it to guide our priorities. So our projects, as Megan said, are supported by a parent partner who helps to guide all aspects of our work, including co-leading our focus groups, helping with the grant application. And the parent partner also chairs our parent advisory committee. So our committee meets once every 3 months virtually, and there's also, they provide guidance over email in between meetings. Right now we have 2 members in addition to our parent partner on the committee, but we have room for up to 5 parents. And what the committee supports us with is identifying and prioritizing areas to focus on, identifying barriers and facilitators for change, reviewing materials to be used, helping guide what information would be helpful for families, and then reviewing and editing the resources that we make for families as well. And members of our parent committee are invited to join our project advisory committee meetings, where our research and healthcare partners are there as well. So on the right of your screen, you'll see a poster we presented at the Maritime Spore Support Unit Summit in 2024. So that was a summit for research, for patient-oriented research. And the poster shares some of our reflections on the systemic barriers and facilitators of parent engagement throughout the Shhh project. So some of the barriers include institutional approval processes that disproportionately affect equity-deserving groups, such as vaccination requirements despite virtual-only engagement, so not coming into the hospital at all, criminal record checks, assumptions of strong literacy and computer skills. As well, also, for example, there's a lack of institutional infrastructure for patient engagement or culturally responsive resources. But at the same time, there are facilitators. So there is widespread encouragement to engage parents in research. There's perseverance from our parent partners despite the barriers. And there's also a lot of educational resources and training that's provided by the MSSU and by CIHR, for example. So we presented these reflections really hoping to just spark conversation about how can we further evolve these current processes to better enable more meaningful and positive patient engagement. All right, and then we have the Theoretical Domains Framework, or TDF, and this is the framework that Momina is using to guide her research on healthcare provider behavior change. Momina is going to go into the framework a bit more later on in this presentation, so I'll just leave that here for now. And finally, we have our Re-AIM framework. So this is the framework we're using to evaluate our work, evaluate our intervention plan, and more specifically, to evaluate the reach, effectiveness, adoption, and implementation. Because of the lifespan of our project, it's 2 years. Maintenance isn't really a focus, but it may be looked at in other projects in the future. As well, we can also look at how our work generalizes to other units, whether that's at the IWK, provincially, or nationally. So for REACH, we want to determine how well knowledge about healthy sleep in hospital and at home has been disseminated. So looking at families involved with the PMU, families involved with the wider IWK health services, healthcare providers working on PMU, or healthcare providers working elsewhere in Nova Scotia. And then what we also want to do is see if that knowledge is changing over time and the awareness is changing over time. And then for effectiveness, we have a few different outcome measures. So we're doing surveys, interviews, we're looking at patient satisfaction measures, and we're also looking at effectiveness for children, parents, and healthcare providers. And then we have adoptions. We also have multiple indicators of adoption. Some of these include looking at reductions in noise level over time, how frequently information about sleep is being included on admissions intake forms, and gathering feedback from families, healthcare providers, and leadership. And then finally, we have implementation. So within implementation, we're considering the consistency of use of our intervention plan, but we're also looking at what's needed to deliver the plan. So the time needed, the financial resources needed, how many adaptations did we have to make to fully deliver the plan? All right. So those were our guiding principles and frameworks. And now I'll just talk a bit about kind of what we're currently doing. So as part of the Shhh project, as Megan said, we hosted focus groups. We had one focus group with 5 parents or caregivers who had accompanied their child overnight in hospital from 5 to over 30 hospital admissions. And we also had 2 focus groups with healthcare providers who represented a whole range of roles on the PMU. So we took audio recordings from those focus groups, we transcribed them verbatim, and we triangulated that data with other data sources, such as poll results. And then we performed a thematic analysis, and in line with our appreciative inquiry framework, we designed our intervention plan. So the intervention plan is multi-level. It targets the environmental, the child and family, the healthcare provider, and the institutional levels, all to support family sleep in hospital and at home. And the current focus of our project right now is to implement, evaluate, and refine this plan. So we refer to this part of our project as Imagine Sleeping, where Imagine stands for implementing meaningful adaptations guided by and informing new evidence. And then the sleeping acronym outlines the areas that were identified as priorities by parents and healthcare providers, and that's what's going to be used to guide the focus of our interventions. Megan's going to go into more detail about that acronym a bit later on in the presentation. So our intervention plan is being implemented sequentially. So it has short, medium, and long-term goals. And like many healthcare improvement projects, the process is iterative. So we will adapt and we will refine the plan as we go along. And we're looking at the data we're collecting and we're hearing the feedback that we're getting. All right, so I'm going to talk about some of the changes that we've already implemented on PMU, but before I do, we did want to know, what do you think is the most common sleep disruptor in hospital? So you can say it out loud, you can put it in the chat, whatever you feel comfortable.
I can only speak to adults because I've never worked at the IWK or with peds, but my background is actually emergency nursing, and I still do shifts at the QE2 emergency. And I would think one of probably the biggest will be the noise level, like the pumps and the machines that never stop beeping for one, and then followed by the noise of people talking in the hallways or in the sort of nursing station, followed by we don't do a lot of overhead announcements. The only overhead announcements that come are from within the hospital, which don't often happen that much. But I would say probably the top would be the machines, like the pumps and the monitors, like if they're on telemetry.
Yeah, for sure. Thank you so much. And I see your answer in the chat, Angela, that you wrote noise and light. And very much on point. So noise is consistently the #1 contributor to disrupted sleep in hospital. And in response to that, we went and purchased this very fancy Sound Ear 3, which you see on the right of your screen here. So the Sound Ear records and visualizes noise levels on hospital units. So currently we have our Sound Ear in the main nursing station on PMU. That's where we've gathered has usually the most amount of noise. And we've been recording sound levels there since August 1st, 2024. And then on the left of your screen, you'll see a poster. So to provide healthcare providers and families with a bit more information about the Sound Ear, we've made this poster and we're going to put it up right beside the Sound Ear, just kind of explaining its purpose and what the different colors mean. So you'll see that green means that the noise level is good. Yellow means that it's too loud and we're encouraging people to go back down to green. And red means that it's much too loud and we need to take immediate action to reduce noise. So we are able to decide at what noise level the different lights show up. And so we will be moving the Sound Ear around the unit and adjusting the noise level limits as we go based on our changing priorities and what we're finding in the data. And then we have this poster that we've also made up to go on PMU. And this is just to feedback some of the noise data that we've collected so far. And we're going to be updating this poster every couple of months based on our recent data. So it gives you an overview of the noise levels and highlights the average noise levels during different times of the day. This one is for the data we collected from November 1st to December 31st in 2024. So we can see that our average noise levels are ranging from 64.9 decibels from 9 a.m. to 6 p.m. to 60.45 decibels from 10 p.m. to 6 a.m. So those are comparable to the sounds of traffic or the sound of a washing machine. And we do see a drop at night, but even at our lowest, over here at 44.6 decibels, we're still significantly higher than the World Health Organization's guidelines of less than 30 decibels at night. There's also many short, loud noises happening above 105 decibels, which is comparable to the sound of a train. So we can see that there was 857 times noise went above 105 decibels between 10 p.m. and 6 a.m. during this time period. And which is great. Since we've put the sound year up on the PMU, we have seen a reduction in noise level from 6 p.m. to 12 a.m. And that's fantastic, but we still do have a long way to go to meet those WHO guidelines. All right, and then something else that we are continuously working on and have already been implementing is information resources for families. So here on the screen is our first resource that we produced that I'm very proud of, and it provides tips to families on how to sleep well at the IWK during their overnight admission. So the resource was developed based on all of the data we'd collected at the IWK so far, as well as the prior literature and the collective expertise of the parents, the researchers, and the healthcare providers that we work with. And so the resource is available in Arabic, simplified Chinese, English, and French through the IWK online library. And then a laminated copy is also available in every patient room on the pediatric medical unit. And currently we're working on developing even more patient and family resources. And we also host opportunities for families and healthcare providers to learn about these resources, to discuss and engage with them. So, for example, coming up very soon in March, from March 6th to 13th, is IWK's first Sleep Week. And so our team will be providing a lot of information during that time and hosting activities to engage the IWK community in healthy sleep and in our research and facilitate access to information. Amazing. So I will pass it on to Momina now.
Hello, everyone. Okay, so I will start off talking about our priorities and how we came up with them. So our two main priorities are the first one being considerations for children with neurodevelopmental disabilities and their families. And this became clear quite early on as we were talking to families through our studies and as well as informally of the families that really are in the hospital a lot. And then we reviewed the literature and we found this was consistent with what we were hearing. And then the second priority is really supporting healthcare providers. And again, this was something that was brought up by healthcare providers as well as families in the literature as to how we can support them best in terms of these interventions that we're implementing. Okay, so we'll start off with the first one here. When we look at the literature, we know that over 80% of children with neurodevelopmental disabilities have sleep disorders, and children with neurodevelopmental disabilities also have co-occurring chronic conditions that do require frequent and longer hospital stays. And then on top of that, difficulties with communication, recognizing and interpreting sensory information such as pain can further risk poor health outcomes. And then sleep difficulties in children also negatively impacts parents and caregivers' sleep. What we know very well from the literature is that sleep is important for recovery and healing, but it is really hard to sleep well in the hospital, especially for these families. So what we know so far from our study is that more than half of families participating had a child with at least one neurodevelopmental disability, and children with neurodevelopmental disabilities were more likely to have a history of hospitalizations and longer hospital stays relative to those without. And in some cases, sleep disruptions continued for weeks after children had gone home. So taking it all together, sleep of children with neurodevelopmental disabilities may be disproportionately affected due to the duration and frequency of hospitalizations they experience. So the James Lind Alliance brings together clinicians and families to determine priority areas to research, and it has worked with the Pediatric Inpatient Research Network to come up with pediatric hospital care priority setting partnership in Canada. And one of the top priorities they've identified by families and healthcare providers is meeting the needs of children with neurodevelopmental disabilities on general pediatric inpatient units. Um, and this priority has also been highlighted by our parent advisory committee, which works closely with us on everything we do. And so taking all this information together, we've considered and factored this into our framework. So imagine sleeping as we think about these current changes as discussed on the PMU. So the second priority is really supporting healthcare providers and how we can do that. We know that with a lot of evidence-based interventions, they can be great, but we do need to make them in a way that is feasible for healthcare providers to implement them, and implementing these things can be influenced by a variety of different factors. And we know that there is a lag between conducted research and its clinical implementation, which is on average around 17 years. So recognizing this, our aim is really to try and embed good clinical practices consistently, gradually, in a way that is feasible for healthcare providers. And so supporting behavior change became a priority for us as we thought about this more. And so this framework, the theoretical domains framework, the TDF, is really helpful in determining specific barriers, facilitators, when implementing various interventions on the unit. And it is composed of these 14 domains that we considered as we thought about this. Okay, so then we took all the data that we've got and triangulated it and mapped it onto the TDF framework, and then identified which domains were most relevant for our context that we do need to then move towards addressing and developing specific strategies to help with them. So when we look at our data, next slide. Yeah. So when we looked at our data, we found that many of our data sources mapped onto these two specific domains. And that is not to say that other domains were not highlighted, but these were quite clear that we do need to do something about them. So the first being skills, and that's the ability or proficiency acquired through practice. And the second one was the environmental context and resources. So really looking at the context that healthcare providers are working at, in, and that environment, whether it encourages them or discourages them to do certain things and do things and gain certain skills and abilities and so forth. So when we look at these two domains, some of the things that we can do for skills specifically is develop healthcare provider training more broadly, as well as specific training for healthcare providers that want to take on the sleep champion role. And that would be a role that would really may require more training and formal and informal talks of, training other healthcare providers and promoting that. And then when we talk about the environmental context, again, these sleep champions could really be a resource for other colleagues on the unit, as well as visual cues that could remind staff would be helpful, things like the sound ear that Victoria was referring to earlier. So really talking about the next steps in our research, we are excited to develop some training programs for healthcare providers currently on the PMU, and then as well as some specific ones for those who would like to take on the role of a sleep champion. And then the plan is to conduct semi-structured interviews to really explore how helpful are these training and resources to gain staff's perspectives on the effectiveness of the current changes we're having on the PMU. And then the gaps that we identify through these will lead to further refinement of our current plans. Okay, I'll give it over to you, Maya.
Okay, so just wanted to spend a moment just talking about what the sleeping acronym stands for and how it evolved. So when we were listening to healthcare providers, one of their concerns was always that anything that we did must take into consideration safety. These are children being admitted to hospital, so there was a concern about how they were doing. So they were very keen that the reason for the admission, the level of acuity of the illness was not overlooked. And so we started off with safety first, really to acknowledge that. What we really heard from families, one of their main priorities was that healthcare providers listened to them. So they listened to what the child's normal routines were, they listened when they were struggling, they listened to what their needs were, and that this was really an active listening between the families and the healthcare providers. So once we'd got these two first priorities of safety first and listening, you can see how, we kind of went, oh. And then environment was something that everybody highlighted was such a big factor affecting sleep. And then, as I say, we were hearing from parents that emotions, their own emotions, their child's emotions, the lack of ability to exercise. You're stuck in a hospital room, you're stuck in a bed. It's really difficult as you're starting to get better and maybe don't need so much sleep, or even when you're poorly, if you're just lying in bed all day, to then go to sleep at night. And for the families, the carers who were staying with them, that was a big issue. And what I found really surprising was just even access to healthy food at regular times was something that was highlighted as an issue. And then I think very intuitively, we would see that pain and comfort was important. And so we had imagined sleep. And then as we were thinking about it and meeting some of our other priorities, we were thinking, well, actually, being admitted to hospital was a real opportunity to identify and perhaps put in place interventions for children with existing sleep problems. So what additional information did we need to know about a child's sleep? What investigations did we maybe need to perform to enable that to happen? And then, as we said, priority, children with neurodevelopmental conditions, and therefore naturally genetic syndromes or complex health needs. What additional adaptations did we need to put in place to support their healthy sleep in hospital at home? And so this sleeping acronym is really there as a prompt, as a checklist, as a reminder. And we're going to be promoting this through posters, as Momina says, through training with staff, that we can just help, hopefully quickly, remind people of some of those really core and crucial things to do when we're imagining sleeping on the IWK Paediatric Medical Unit. So question number 4, will you consider including any aspects of sleep in your research in the future?
I think you sold me. And I don't do, like right now, I don't do any type of research that I could include sleep, but I do research in the emergency department. A lot of it is around like um, uh, triage time, wait time, that sort of stuff, and being able to look at other things like delivery of healthcare services while patients wait. But this is so interesting. I loved that that one diagram you had where the noise level and you show it what it would look like a train or a washing machine, because people respond to that so much more than if you tell them how loud something is in the more scientific terms. But I think one area that a lot of what you're finding could really translate into adult is with the geriatric population, because in emergency, I would say 80% of what we see are from nursing homes or coming from home that have, sleep disorders or cognitive issues. And the sundowning that happens in emerge with, because there are no windows in any of the patient rooms. So you talk about light, it's non-existent. Like natural light is non-existent there. And the lights in the rooms are brutal. They're those horrible halogen lights, which I can't even have on for a long enough time because it gives me a headache. Imagine in these individuals. But the noise, like as I was saying, the noise of the monitors, but even like we have the hallways are lined up with ambulance stretchers and ambulance and paramedics that all they do is talk 24/7 because we don't have beds, so they line them up there, which is right near a patient room. So the noise from that side, and then the noise on the other side, which is where all the doctors and nurses sit, you're not going to get a moment of quietness in that. And the confusion I see with the elderly because of the sleep deprivation, like I think it would be an amazing study idea in emerge. I don't know. I wanted to ask you, do you look at emergency or is this more admission, like in the admitted floors?
Yeah, no, it's a great question. And so what's the moment we are concentrating on is a pediatric medical unit,
Okay.
but we are, when we do the healthcare provider focus groups or interviews, anyone who's involved in the pathway can be involved. So if there was an emergency doctor who wanted to, be involved in those discussions, we're really interested in that whole pathway. But for the families, we have just concentrated when they're actually in the pediatric medical unit. But what you say is so interesting because there's quite a lot of research that shows that if you have sleep disorders, you are much more likely to be admitted to hospital. And the very sad thing is, you're admitted to hospital, you kind of patch back together, your sleep disorder is never addressed, you're sent home again, and you run into your next health crisis.
And
your sleep, yeah, and honestly, my problem is not just trying to solve all the world's problems in one go and trying to restrain. So what I'm trying to do is do a lot of awareness raising so everyone else can solve all those other problems as well.
That makes sense. No, I mean, I think you have emergency is a different beast because of that. And the sad thing is we have patients that are admitted there for days, even weeks sometimes. So some spend their whole admission in emergency. Can you, like, how horrible is that? Just even if the sound wasn't a problem. So I think this really, I hope it does inspire others to look at, in adult, especially in the emergency department. And definitely, if there's any way I can, I will consider it because this is so interesting, so important. Yet I know for myself, I wouldn't even necessarily have thought about it. I'm just curious, what sort of triggered it for you to as an interest to
So I have personal lived experience, and
Okay.
I've had so I've been in hospital, and I could tell you all sorts of stories
Mhm.
about when I was 17 about that, and then I've had my kids in hospital, and I was ready to murder everybody
Okay.
because we just were not getting sleep,
Yeah.
and then it was kind of like, hang on a minute, why is everyone just accepting this? Why is this? And then I started looking into the literature and found out I was not alone. This was an issue, and it's really taken off over the last few years. So
No, I
yeah.
think it's so interesting, and I love that you took a personal experience, and then because I think those mean the most, those research that have that personal, really, like I often find things from my clinic from as a clinician, and then, but personal is fantastic because you have that experience and you can relate, and it just makes so much more sense when you're investigating and looking at the literature. So yeah, excellent work. So nice. Thank you so much for presenting. It's opened my eyes to like I need more areas to research, but this is so cool. Very cool. I love it. Yeah.
Perfect. So I think, and that was just us at the end. So I'm just going to stop sharing. Here we go.
I was just going to ask, are there many people researching sleep? I know Penny Corkum does it at Dal. Do you work with her?
Oh, yes. Yeah. So one of the reasons I came here was because of Penny Corkum's work and also because of Isabel Smith's work. So my kind of two interests are autism and neurodevelopmental disabilities and sleep. And so, you know, we had a lovely little nest of research here, which I thought I could just segue into. So
Nice.
yeah, and they've both been enormously supportive. People researching sleep, I would say, so I think Angela has to listen to me again tomorrow, so she'll hear some of this tomorrow. But really, in pediatric sleep, it's in its infancy. No, it's still quite young. So the International Pediatric Sleep Association is celebrating its 20th year this year. So pretty young. If you look at adult sleep, you can go back to the 1950s. And then if you look at our philosophers, you know, you can go back to Plato and people like that who would, you know, ponder on sleep. So I just find it completely fascinating.
It really is. Yeah.
Excellent. Thank you. Well, I guess I don't know if there's any other questions, but thank you so much. This was so fascinating. I really, really enjoyed this, and it has made me think now. But thank you so much. And you never know, I might reach out to you one day, Megan. Just like, remember me? Yeah.
I have an extra question.
Yeah, please
if
go
that's
ahead.
possible. So
Yes,
yeah,
for
first of all, I
sure, for
just
sure.
want to commend you for all three of you for excellent presentation. It was really interesting, and I'm myself definitely work with kids on the spectrum. I've done research kind of more towards like intervention, working on kind of language. And in particular those kids on the spectrum that are minimally speaking. And I can tell you more often than not that yeah, it's definitely a very prominent piece, even children that haven't been hospitalized but are on the spectrum, at least in my anecdotal experience. And I can't emphasize how much I feel that sleep is such a foundational thing, and then it impacts parents' sleep. And then it's just this cascading effect of it's really hard as a clinician to be in the home working on different things when sleep isn't kind of, to your point, not addressed. And I guess my question was, I found it really, really interesting, the use of your parent advisory committee. And I thought that was really quite nice. And I just was wondering, how did you go about designing it and like recruiting those parents? Yeah, just because I just feel like it's such a valuable contribution and really nice to have them there for the co-design.
Victoria, do you want to answer that?
Sure. So the framework of how it was developed really just came from the training that's provided by CIHR and the guidelines, in terms of how we developed kind of like the onboarding process, and yeah, the framework of it. But the recruitment we placed on the IWK volunteer opportunities. There's a page for patient-parent engagement. So we did that. I'd say a lot of our recruitment for anything we've done with families is a lot of it is actually word of mouth. And families just talking to each other and be like, well, I have this friend and I have, that's basically how we got all of our recruitment for anything. So that was really good. We also reached out to our initial project for Sleep for Health in Halifax. We reached out to all of the families who participated in those projects who consented to be contacted later on to see if they wanted to be involved with Shhh at all. And yeah, anything to add, Megan?
Yeah, no, that's perfect. And you know, how we got our parent partner was very fortuitous. So, have you got 2 seconds for the parent partner story? So basically, in the middle of winter near where I live, I was out for a walk with my husband and dog and spotted some otters swimming in the sea, which was very beautiful. And a man and his wife and his daughter, who was in a wheelchair, went by, and I said, "You must come and look at the otters." So they obediently did what I told them to. They came and looked at the otters, and we started chatting and discovered just so many similar interests. And the father said, "I would love to be involved and, support you. And how do we go from here?" And his wife went to school with, I think it was Penny's brother. So, it's again, I do find these, connections great. So I would say seize every opportunity and you will get an amazing team working with you.
You.
Brilliant.
Probably shouldn't have had that on the recording, but anyway.
That's such a great story,
that
and
story.
that's so like Nova Scotia. It's like someone knows someone, went to school. It's not like that's so typical. But thank you. That was very interesting, and best of luck to Victoria and Momina with your work and your studies. And yeah, thank you. It was very nice. Great work.
Thank you so much.
Thank
Take
you.
care.
Thank you
Bye-bye.
all. So nice to
Bye.
meet you.